and it is my pleasure to present Natalie Napolitano. Natalie is currently the Research Clinical Specialist and Program Director of the Tobacco Dependency Program at Children's Hospital of Philadelphia. Along with her current position at CHOP, Natalie is also the Respiratory Therapist Project Manager for Prospect Trial. In a few special projects, near and dear to Natalie's heart is her travel that she does to Haiti annually, supporting the respiratory care training program in Malat, Haiti. Ms. Napolitano has a vast number of peer-reviewed publications, abstracts, as well as have lectured around the world. With active membership, including our local Pennsylvania Society of Respiratory Care, where she currently serves as Vice President and co-chairs the Pennsylvania Respiratory Research Collaborative. Nationally, a proud member of the AARC for more than 2 decades, and currently active on the Government Affairs Committee and Fellowship Committee. I want to thank Natalie for being here with us today.
All right, thank you very much, Winnie, and good afternoon and good morning to everyone. Happy to be here today to be able to present this information to you. So we'll be talking about how we care for our little ones with BPD, and really what are some of the outcomes and some updates and different things, as this is more of an evolving disease and we're learning things every day, and there's a lot of research that continues to occur on a daily basis. First and importantly, any conflicts of interest. I am in a research role, so somebody's got to pay for this research. So we have research partnerships with both Philips Respironics and Draeger Medical, and I also have consulting relationships with Vero Biotech and Smiths Medical. All right, thank you for that, Winnie. Okay, so we'll start with kind of defining what BPD is. This definition we think would be is what it is, but that's not really true. The definition continues to change over time. We had what was the old BPD, which predominantly was the disease prior to us having widespread use of surfactant. So we will still refer to some kids as old BPD, but generally it's when they've come from other countries that don't have the wide availability of surfactant, or if they didn't receive it kind of when they should have at their disease time. Then we have our new BPD, and this is really refers to the development of immature lungs, because babies are being born earlier and earlier, and it's really characterized by an impaired alveolar development with less number of alveoli, and really that's a failure of growth, and it's really not just of the lungs, but also their vascular proliferation in the late gestation, so they don't just have the rest of the growth of their lungs, but also everything else that's going on. And we're starting to see, as we dig more and more and do more and more studies with these babies, we're finding a lot more things. It just makes sense. Everything stops growing when they're born. And then we have this term chronic lung disease, which is used more commonly now for a multitude of different conditions and age groups, but it's not really a real diagnosis. So we really want to make sure that we're trying to stick to particular diagnoses that have real definitions. And really, this predominantly BPD is characterized by an impaired alveolar growth and airway inflammation, and we're seeing that in many different ways. So in 2001, the NIH formed a consensus group to try to make definitions so that we could have this clinical definition of BPD. And they came up with treatment with oxygen greater than 21% for at least 28 days. Plus, there were some additional categories that went into this. And this is a definition that is utilized by most scholars in the US. And it takes multiple gestational ages into count here. However, these classifications have some challenges. As you can see with the 2 separate diagnostic groups, we're stratifying this definition by whether or not you were born before or after 32 weeks gestational age. And then really, it's difficult to add all of this up, particularly from a center like CHOP, where we don't have these children at birth and we don't have complete records. So it's hard to really know how many days they actually received oxygen and where they were on day 28 or day 56 post-menstrual rate. So it gets a little bit difficult with these. Plus, really, there's a lot of times that we have children on very high levels of support but no oxygen. So why is oxygen the only criteria? So then we had a little bit of an expansion of these. So if you're looking at your kids less than or greater than 32 weeks, we're looking at mild, moderate, and severe. And this then puts everybody who is getting any sort of positive pressure ventilation greater into this severe category. So you can be on a CPAP of 5 with 21%. You can be on O2 at 0.25 liters. It's kind of where do we draw that line? And when, particularly in situations where we can't analyze with these lower flow nasal cannulas. And as everybody, if you're on full ventilation trach with a PEEP of 18 versus non-invasive with a PEEP of 5 and 21%, you're all stuck in this severe category. And is that really fair? Are you the same type of severe? So because of that, there was an update in 2016 by NIH and NHLBI. They convened a new consensus group, and this was published in Journal of Pediatrics in 2017. So they kind of re-stratified this severe group into type 1 and type 2. And you can see here that they're looking at if you have oxygen greater than 30%, or if you're on non-invasive CPAP or high flow nasal cannula, you're kind of this type 1 severe, and then type 2 is if you're receiving mechanical ventilation. And that really helped us to differentiate between invasive and non-invasive. We now have a new definition that's kind of come into play, and Eric Jensen at CHOP has kind of done this, really taking a look at how do we better incorporate high flow nasal cannula, because we're not sure that it really goes into that severe category, and really these definitions help us predict childhood outcomes, because that's really what our parents want to know. And long term, once you're out of infancy and you're 12 years old, should you always have this severe BPD diagnosis attached to you when that's not really what is predictive of what your current morbidity is? So he took a look at a large group of patients in a database through NICHD for all infants born less than 32 weeks between 2011 and 2015. And there was 18 different centers, and really tried to help predict death as well as serious morbidity with clinically meaningful respiratory and neurodevelopmental outcomes all the way out at 18 to 26 months of age. So this was a large data set, and predominantly a retrospective look back to see where these kids were at birth, what type of respiratory support they were on, and then when you get to 18 to 26 months of age, when you can really do your good neurodevelopmental testing like your Bailey to really tell, how does this definition really tell us long-term what's going to happen. Respiratory support at 36 weeks corrected gestational age, and again the Bailey 3 at 18 to 26 months of age to really help make these deciding factors. And he broke these down into 18 pre-specified definitions that they then analyzed into one definition that came most closely with that 2001 NIH definition. So these are kind of our new definitions and new guidelines that we really want to see used moving forward, because it really better represents long-term morbidity. So at 36 weeks corrected gestational age, if you were on no support, regardless of what you were on prior to that, how much oxygen for how long of a time frame, you no longer are considered having BPD. You do not get this diagnosis. If you're on a nasal cannula less than or equal to 2 liters per minute, then you are grade 1. Grade 2 is a nasal cannula higher than 2 liters per minute or any non-invasive positive pressure ventilation. And then grade 3 is if you're on any sort of invasive mechanical ventilation. So it kind of took away the oxygen definition and took away that stratification of less than or greater than 32 weeks, and really that complexity that we were seeing with that. So this is something that we will likely see moving forward as kind of this new definition, as it gives us a better idea as to actual long-term morbidity. So when we're looking at BPD, it's really a disease that involves the entire lung, not just pieces of it. And this is something that we'll try to really show you some information on how we treat the different types of phenotypes. So it's the disease of the lung parenchyma as well as vascular lung disease. We're seeing a lot of pulmonary arterial hypertension, a lot of veno-occlusive disease. We're also seeing small and large airway disease. We're seeing malacia. We're seeing stenosis. We're seeing kids that have some really hyperreactivity and are very responsive to bronchodilators. And then we're seeing some diseases that have different underlying pathologies as well as a lot of very mixed pathologies. So if you take a look at these 3 different CAT scans and x-rays, this is all 3 of these children have BPD. But you can see that they're very different phenotypes and very different types of disease. And as you can imagine, you're going to ventilate these kids very differently depending on what that x-ray or that CAT scan looks like. And we started seeing this a lot in our kids where we couldn't really treat them all the same. So we did a look back and saw 3 different primary phenotypes through of how we're testing these kids. So we looked back from 2011 to 2015 and categorized 73 different infants that all had CT scans, chest CTs, and we do a controlled ventilation CT so we can really see inspiratory versus expiratory films. And then they also had echoes as well as some sort of a bronchoscopy or tracheostomy. Somewhere we're doing an actual visualization of the airways to see what type of airway disease. And as you can see, a lot of these kids overlap. So we have about 8% that had only pulmonary hypertension, 7% that had only large airway disease, 12% that only had that lung parenchymal disease. And then you had some overlap of 2 or 3 different types. And unfortunately, the largest percentage, 32% of these kids had all 3 different phenotypes. And then it's very difficult to target your ventilation and your therapies when what you might do for one negatively affects the other. And that's what makes these kids so challenging. So going into this challenging management, we have these combined physiology of severe injury and arrest and development. And we can present, it can come to us very different ways. I have some case studies that I normally take a look at, but I was really running out of space. So if we have time in the end, we'll kind of go through some of these case studies where things may present one way, but then show up another. So it's important to really do a lot of the different diagnostic tests to really help figure that out. And then really define the treatment. There's really no definitive treatment one way or the other. So we're doing a lot of research studies to try to help us figure out how to treat these babies. So it's still a learning process, continuing over time. We're getting more and more information. There isn't a best way to prevent BPD either. This is obviously going to be the best option, and there's large practice variations in how to do that as well, but really preventing it is going to be the best option for long term for these babies. So issues in lung tissue disease treatment, we really need to do our best to try to optimize their respiratory support. And sometimes you have to ask yourselves when to admit defeat. So is non-invasive ventilation always the best option? And in preemie treatment, we want to keep off invasive mechanical ventilation for as long as possible and keep them on non-invasive. But at some point, is it at that 32 weeks? Is it at that 36 weeks mark? You have to look back and say, yes, I'm on non-invasive, but at what cost? Are they growing? Are they able to do anything that is a normal life function of a baby without falling apart other than just lying there and breathing? And if that's the case, then we're not supporting them appropriately, and then intubation and invasive mechanical ventilation may be the best option for them so that they can open their eyes and look around and play and do therapy and sit up and get their diaper changed without coding. Being able to poop is a major function for babies, and if they can't do that without completely falling apart, then we're not supporting them from a respiratory standpoint anymore. And that's when you really should be able to say that we have to admit defeat, and non-invasive ventilation is no longer the best option for this baby. And we need to kind of move to that chronic ventilation standpoint from really still preventing things. Other medications that we can use that have been shown to help, but we're still doing a lot more research on, is diuretics, steroids, both inhaled and systemic, and bronchodilators. And then there are other factors that really can affect their lung disease, such as microaspiration, if they have some sort of an infection going on that may look like a big bleb on the x-ray, but if you don't get further diagnostic testing, you won't see that that's a loculated kind of infection that we can just drain and treat with antibiotics, then they're fine. We've had a couple of kids that came to us that way that looked like one big bleb. We thought we were going to have to take a lobe out, and under further diagnostic testing, it was MSSA loculated. And once we drained it and treated them, they left on room air. Was wonderful. So this extra testing is really important. And then really inflammation is a huge piece that we need to try to get under control. So a lot of the treatment strategies, unfortunately, there's no consistent effective treatment that we can apply to everybody to prevent further damage and to support our babies to grow. We really have to look at all the different things to support them, as well as do different trials of treatment to see what really happens. And when we're doing these trials of different treatments, we need to make sure that we're defining what is our measure, what are we trying to see a difference of, and what's our endpoint going to be. So for example, if you're going to trial bronchodilators and see if it helps, what are we hoping to see? What's our effect? I want to see a reduction in the PIP because we're on volume controlled ventilation, or I want to see a larger amount of tidal volume, exhaled tidal volume after therapy. And we're going to give it a try for 48 hours. If we're not consistently seeing that, we're going to stop and move on to the next treatment options. So you have to have kind of what are your clear goals and what's your time frame to see that goal, so that we know that something's working. Otherwise, we end up with the kitchen sink and the bathroom sink and everything else thrown at these kids. And then how much of that is compounded into being problems as well, of getting too much therapy. Nutrition also plays a huge role. Yes, these kids have a really hard time breathing, and yes, we're having a really hard time trying to manage them, but they've got to grow. It plays a huge, important role in the supportive care, and there's no way to really determine, unfortunately, what is appropriate nutrition for children. A lot of our guidelines come from the World Health Organization, which is based off of normal, healthy children and what their calories should be. And a lot of times our nutritionists will throw in these severity of illness calculations and stuff like that, but we still don't really have a great option to say what is adequate nutrition. We oftentimes will see that our kids are growing wide but not long, so then we'll have to go back and say, okay, we need their growth trajectory to change a little bit, so we'll add some more proteins and take some other things out, and really started looking at how do we, try to have COPD patients eat, because we don't want that buildup of CO2, so we got to build it, peel off those carbs and have more lean proteins and get that all into a formula. So some of the same strategies we're trying to apply here. Often we do end up with overfeeding of these babies. So we have nutrition as part of our multidisciplinary team, and every week we're looking at this because it's huge. It's really hard to get these kids off of their ventilators or wean down their support when they have a humongous abdomen. So we do try to make sure that we're watching their linear growth very closely. But we do need better ways to really collect this information. Most indirect calorimeters have limitations of tidal volume where you really can't go below 50 or 20, or they have limitations with too high of FiO2. So we still haven't found a good way, unfortunately, to do that just yet. And then again, we really want to make sure, sorry, I already said that, we're watching closely. So here's one of our little babes that has some disproportionate growth. And as you can see, he's a bit of a Buddha baby. And over time, we're watching his growth, and his length just started to fall off. And right about that point is where we intubated him. And then he was able to be able to start getting some linear growth as well. And you can see, again, we have another baby here who was 26 weeks, was on a ventilator for 8 weeks, multiple failed attempts. And this last extubation, you can see our growth kind of stabilized off. And then once we reintubated, we were able to get linear growth back. So that's one of the ways that we can really help tell if we can't grow, then we're not supporting them from a respiratory standpoint as efficiently as we probably should be. So we've started using that as a really great marker as well to know when we extubate somebody if they're actually getting what they need. So looking at some of our different treatment strategies for accurate respiratory support is really important. Making sure we're giving them enough, but not too much. We don't want to make them work too hard. We don't want to make them have multiple hypoxemic episodes over time. And if that's happening, then we might need to give them a little bit more support. We want to have accurate PEEP levels. Neonatology over a period of time became very PEEP phobic. And we have found that you don't need to be as afraid of PEEP. It really is that baseline of your mechanical ventilation support. And if that's off, you're going to need extra support than you otherwise would have needed. So, don't be afraid to go up on that PEEP a little bit. It can help with comfort. It can help with synchrony. And I'll show you some data that we found that really supports that. And we also get chest CTs. And this helps us to determine the quality of the lung tissue, if there is any recruitable lung available, to help us make that decision as to how high our PEEP should go. If there are cystic or overinflated areas of the lungs where we might have two separate time constants that we're trying to ventilate with, which can even make it more difficult. But it changes your strategy a little bit to see how you can best optimize the ventilation and oxygenation. So this is a great graphic that I found in a 2015 publication that really shows us all of the things that go into these intermittent hypoxemic episodes. And when we're trying to decrease these, kind of looking at what can we actually control. And it's the right side of this. We can control when they get a decrease in FRC, that they get poor respiratory function, then they have low O2 reserve, and then they have these low baseline sats. And if we're going to have a hope of helping to improve their neurodevelopmental outcomes, we really need to stop these intermittent swings, because we know from past research that that kind of helps to increase the risk of getting a brain injury and having these longer term neurodevelopmental markers. So anything that we can do to help stabilize their FRC, and PEEP is one of those things that we think can really help do that, to help them have more of a reserve so that they can then go on to be able to handle certain life-changing events like pooping without completely desaturating. So we did a point prevalence study in October of 2019, and there were 12 different centers internationally that collected data, and we went off of the NIH definition for severe BPD, because the new, we just call it Eric's definition, hadn't come out quite yet. And this was done through the BPD Collaborative, which is about 23 centers internationally that have specialized BPD programs that do a lot of the research looking at these babies. So we all kind of ventilate differently, and that makes it more difficult to do studies, multi-center studies, when we have to try to get everybody to have buy-in on one ventilation strategy to give it a try and do it the same way. So we took a look at, how are we really ventilating these babies, and is there as big of a difference as we all really think there is? So on October 29th, everybody looked at all of their infants that are admitted into their programs at that time, and we had 163 eligible infants. So it was about 14% of the total census at the centers had severe BPD. Most of these children were born at 25 weeks and were about 700 grams. Predominantly, they were male. And at the time of the study, they were about 47 weeks corrected gestational age, and were a little over 4 kilos. And over half of them had a tracheostomy. And then at 36 weeks, we looked back to see what type of support they were on. And predominantly, there was a good split between invasive and non-invasive ventilation. And then we have that percentage that was unknown, because they're now at a tertiary referral center like CHOP, where we just didn't have that in their past medical record to really have that information. Sometimes we don't get a good set of medical records from the referring center, unfortunately. Then when we looked farther into how do we really ventilate these kids, the predominant amount of them were using a pressure controlled ventilation over a volume controlled ventilation. But when they're doing volume control, most were using some sort of an adaptive mode, which is PRVC or volume control or volume guarantee or volume control with autoflow if you're a Draeger user. Anything that it's really, that's more of a pressure mode with a targeted tidal volume. And then we did have some that were on NAVA. And then we did have, from a non-invasive standpoint, the majority were on high flow nasal cannula or nasal cannula, with a few on CPAP as well. When looking at our actual settings and the ranges of settings that we use, our PEEPs are anywhere between 7 to 13. On average, tidal volumes around 6 to 10 per kilo. I times were longer in most NICUs, approximately 0.6 seconds. That's one of those settings that's the set and forget in NICUs, and then these kids are perpetually on like a 0.3 I time as they continue to grow, and that's one of the things that we can do to really contribute to that bedrock of getting their settings set up appropriately, is let these I times grow with these kids. And then our PIPs were high. We're allowing PIPs in the 40s on the majority of these patients. So we're also looking at all the different medications that were delivered to these kids. That's going to be in a different manuscript, and we haven't gotten kind of an estimate of that out yet. So there's more to come as well, just to see how people are currently treating these kids. And this information is going to help us to then decide to design some ventilation studies going forward to see the best ways to ventilate these kids, and then really knowing which sites would be most likely to help enroll in these kids because it's closest to what their current baseline is. So looking at ventilator synchrony, this is something that we look at a lot in our unit. We have a lot of kids that are very desynchronous with their ventilator, and they are missing a lot of breaths. They have a lot of wasted effort. So all the things that we look at and we tweak are listed here. We use a lot of cuffed endotracheal tubes. We use a lot of predominant volume ventilation. We are what is called a high PEEP center, and you'll see that in some of our data and studies moving forward. Our I times get relatively long, and really what we did is we kind of looked at how we ventilate COPD patients and what's the best way to get them to synchronize, and then that's kind of what we tried to employ. If you would look at 2 CAT scans side by side, one of a severe BPD patient and one who has COPD, they look relatively similar. And if you adjusted the scans to look like they have the same size chest, you're not going to know a big difference in somebody. So we tried to use some of these strategies, and some of them are working. They really are. And really the goal that we're looking at when we're making some of these changes, are we able to eliminate or significantly reduce the wasted efforts? And that is going to help so that they're not using as much of their energy on breathing or fighting against the ventilator, and then they're actually going to start growing. And when they can start growing and they can start tolerating more of life, then they're going to start building up all their accessory muscles, and their diaphragm can actually do something, and then we can start weaning them. And we really had to go back to the basics, and we have to make sure that all those basics are where they should be before we can move forward with additional strategies. And the first is really setting I time. If you're watching and monitoring your flow, then your flow time tracing, you're going to see where you really can be and where you should be. If it's cutting off into exhalation before you get back to baseline, it's too short. If you're sitting at baseline for a long time before you go into exhalation, then it's too long. So it's kind of that Goldilocks. And this is one of those things that we should be assessing on a daily basis to make sure our I time is appropriate for what that child's need is for that phase of their disease process. And then we also can look at synchrony with our I time by looking at your pressure waveform. If you're getting that little bit of a peak and that active exhalation on pressure, and you can also see it on your flow time tracing, then your I time is a little bit too long, and you should be letting them get into exhalation there as well. Then let's talk about PEEP a little bit. This is one of the most controversial ones I think that has come up so far. So there's a lot of ways that we use PEEP. It's the set level of pressure that remains in the lungs when we exhale to allow glottic closure. We know all these baselines. When we're doing extrinsic or applied PEEP, this is what's coming from the machine. But we also have to be aware of what our intrinsic or our auto PEEP is, and that is resulting of these incomplete exhalations where these babies just can't get all of this out. And again, this is kind of the bedrock of our ventilation settings, and is really the first thing that we try to set appropriately with our I times. So traditionally, we use this as this baseline, regardless of lung disease, to compensate for bypassing our glottis. We use it for hypoxemia, for atelectasis, for pulmonary edema, for pulmonary hemorrhage, all of these usual pieces, as well as for airway collapse, if there's some sort of airway compression, like a tumor, or if they have malacia. We're trying to stent the airway open. And then we have our non-traditional uses, which is kind of where we fall in with our severe BPD kids. So we're looking at lung mechanics. We're looking at low lung compliance and high resistance. So when you're doing a PEEP titration maneuver to figure out where your best PEEP or optimal PEEP is, particularly in your ARDS patients, this is what you're going to look for. What PEEP can I get my best compliance and my lowest resistance? And then patient ventilator asynchrony, and this is where we use it a lot in our COPD patients and asthma patients. So if you're seeing wasted efforts where they can't trigger when they're trying to spontaneously breathe because of their auto PEEP, there is airflow limitations, or it's a high minute ventilation, or they have this high expiratory resistance. So we also then use it for these combined lung pathologies. So if they have lung tissue disease, they have atelectasis or fibrosis, or these cystic or bloodulous air spaces, and then we're going to add in some stenosis and a little bit of malacia just to kind of pepper it off there. This is where the PEEP settings can really help of setting your PEEP according to your pathology and knowing why your PEEP is set that way. So if you're setting your PEEP to stent open malacia, then you shouldn't be titrating it according to oxygenation. So you really want to make sure that there's clear communication as to why you're setting your PEEP a certain way. And sometimes we do measures in all three areas. We're looking at our compliance and resistance, and then we also looked at our controlled ventilation CT scan, and then we did a bronch, and we set the PEEP off of where's the lowest that we can get to get the best benefit. And we have to really make sure that that is made clear. The way we assess for mechanics for the best PEEP setting is we do what we call a PEEP grid, which is essentially a PEEP titration. It's that staircase PEEP recruitment where you're looking for optimal PEEP. It's predominantly done in pediatric and adult ARDS patients. And then we're calculating, we also now actually have added a driving pressure calculation as well, as we're looking to see if that's a meaningful parameter in these kids. And then we're really determining the PEEP off of the needs for their lung tissue disease with this type of a procedure. So the docs will write the order for the PEEP grid. They write the ranges that they want the PEEP to be tested. And then I have a spreadsheet that I'll show you in a minute that kind of auto-calculates all the therapists use, and then we can cut and paste the values as well as the graphs into a note so that it's there so everybody knows why we're doing what we're doing. So we use true volume control ventilation for this, so no auto flow, no volume guarantee, no PRVC. You need to be in a true volume control mode, which means your PIP's going to be higher, and we just have to kind of tolerate that and remember and remind everybody else around us that the pressure that you see at PIP is not what's being translated to your lungs. That's really your plateau. But in order to get these measures, you need to be able to get a plateau measurement. So we set our I time so that we can get a brief inspiratory pause for our plateau instead of doing an inspiratory pause and trying to coordinate that with the baby. And then we do a stepwise PEEP titration where we'll start low and go high. And we start 5 minutes, take some measurements, get 3 good breaths, take our measurements, and then we do the calculations. This is what our PEEP grid looks like. This is the spreadsheet, the first top part of it. I kind of have all the calculations in there, so it's locked down where the staff can only type where it's yellow or to enter their PEEP in that first value under that first waveform. It says PEEP, and then it auto populates below for the calculations. And here's kind of what one of our PEEP grids looks like in the end. Where the summary table auto-calculates. It takes the 3 different breaths in their calculations and summarizes them together, and then populates with your compliance being on your left-hand axis and your resistance being on your right-hand axis. And then for this babe, you know, we looked for where is our best compliance and our worst resistance or lowest resistance, and that was a PEEP of 18. And yes, we've set this child on a PEEP of 18, and they were completely comfortable and had no more wasted efforts, and they were safe and fine, and there were no pneumothoraces. So we use some relatively high PEEPs. And then we'll look at PEEP to see how we can best offset intrinsic PEEP. So intrinsic PEEP is that incomplete expiration prior to the start of the next breath, and that's when you're going to get some air trapped in your lungs. again, high minute ventilations, incomplete expirations, and any of your flow limitations. And then really, in the adult world, you can do an expiratory hold where they're not trying to breathe through that hold, and then you can assess off of your flow time scalars as well. And then you can really do a count and do an assessment for wasted efforts. And the way that we do this clinically at the bedside is, you know, placing your hand on the child's abdomen, kind of right where their rib cage ends, where you can feel them start to take a breath in. Set your phone timer for 1 minute, watch the ventilator, and every time you feel them take a breath, but they do not get a triggered breath on the ventilator. And that is how many wasted efforts that you'll have in that 1 minute time frame. So we'll do that calculation sometimes. A lot of our attending group on our chronic lung team uses that measure, as well as pulmonary, every time they're doing an assessment to really get a gauge for how many wasted efforts they have. And we use it as a measure in some of our research studies as well. The other option, which I'll show you next here, is using esophageal pressure monitoring, which is not something that's traditionally used in the neonatal realm. But we did a little study on it to kind of prove our point that intrinsic PEEP does exist, and that it can be offloaded in this population. So if you have a high intrinsic PEEP, your diaphragm is flattened, you're going to have negative, you can't really generate those negative flows to even trigger at a very low trigger of 0.2 liters per minute that we have set on most of our babies. So we're just setting them up for failure by letting this intrinsic PEEP to just rise. So if you're trying to assess this off of a flow time tracing, you can kind of see it here where the red arrows are, where they can't trigger. They're trying to trigger and they just can't do it. So one on the left, you see that negative and they get that trigger. On the one in the center, they're trying to trigger and they're not getting it. You can see where that waveform kind of dips down and you have that intrinsic PEEP. So we did some esophageal pressure monitoring, and this is widely thought to be a good surrogate for your intrathoracic pressure. And really, when you're trying to use this for a precise measure of intrinsic PEEP, you need to be able to see it with concurrent airflow tracing, your esophageal pressure and your airflow, to really calculate the optimal PEEP. A lot of the adult units will take an esophageal pressure catheter and they'll transduce it like they do an art line, but they don't have that concurrent waveform tracing. Doing it that way is another measure of how to set your PEEP, not for synchrony. So it really needs to also be performed on a spontaneously breathing patient, because you need to know the only way you can measure intrinsic PEEP is if you can see that time lag between trying to trigger a breath off of their intrinsic PEEP or their esophageal pressure and when they actually get one. And I'll show you that as we go forward. So in all the adult literature for COPD, they say you set your applied extrinsic PEEP at 80% of what your intrinsic PEEP is, and that'll help to reduce your synchrony. So you don't want to match it 1 for 1. It's at 80% so that you're not risking any of that giving overpressure. So this is a much older study, but it's really good at kind of baseline that tells you how we're measuring this intrinsic PEEP with using esophageal pressure monitoring. And you can see when we have the start of an inspiratory effort from the esophageal pressure versus when you actually see the flow tracing start for the inspiratory breath, that change in pressure there, that's what your intrinsic PEEP is. So in this graphic that we're showing here between those two time frames, our intrinsic PEEP is 6. It's the difference between 2 and 8. And that is what it would be for this patient. So here is where we have a PEEP setting on a patient for a study that we did. And we are looking at our PEEP setting for hyperinflation. We have our PEEP grid, and then we have our intrinsic PEEP measurements. And really, there's a lot of different ways that we're looking at a lot of these waveforms. So we're looking at our PIP, we're looking at our plat, our volume, and our flow that are all calculating into all these different measures. I apologize, that's a duplicate slide. So looking at asynchrony, we have a child here that we started on a PEEP 16, and our intrinsic PEEP is 18.5. And you can see here at this measure, we have active exhalation going through an obstruction almost. That's what this little circle marker is telling us here. We then increased the patient's PEEP to 18. We didn't go all the way up and match it. So if I was true intrinsic PEEP, as I'm going 18.5 above my 16. So we just kind of did a stepwise increase, knowing that our disease is a little bit different, and who really is going to set over 30 a PEEP on an infant right away, even we're not that crazy. So on our next, we did a PEEP of 18, and our intrinsic PEEP dropped a bit more than just the 2 centimeters of water pressure. We were at 13.2, and we were able to overcome that active exhalation, as you can now see that. We're not pushing through an obstruction anymore now here. And then we went up to a PEEP of 24, and our intrinsic PEEP was 1.3. So we did it up, we went to 20, we went to 22 before we hit 24, but we had to go up to a PEEP of 24 on this baby and overcome a lot of that intrinsic PEEP. We eventually on this child settled on a PEEP of 22, and really that stayed there for about 24 hours. And they didn't need any rescue sedation in that time frame, which was amazing. And the parents were just thrilled. They watched this baby over that 24-hour time frame and saw them so much more comfortable, and said to us that this is a new baby. They were interactive, they weren't desaturating every time they needed to get their diaper changed. It was really incredible difference in how the baby looked on a PEEP of 24. So we did the study that we published in Pediatric Pulmonology, looking at 12 babies with severe BPD. And one, we wanted to prove that intrinsic PEEP actually exists in this population, because there's a lot of people that didn't think it did, and that it actually causes asynchrony, because again, a lot of people didn't think it did. And if you look at this tracing, you can actually see a lot of the wasted efforts here. The ventilator breath is that larger breath, which corresponds with your red flow waveform above. All of those spontaneous breaths below are wasted efforts. There's actually no ventilation being given to the patient at that time, and that was just amazing to us, where we could help to really prove that and see all these wasted efforts that in a clinical assessment we thought we saw, and now with the flow tracing we were seeing this. So for our study, on average, these babies were 24-ish weeks at birth, around 700 grams. Their weight at the study was around 5 kilos, and approximately 48 weeks corrected gestational age. And their starting PEEP was anywhere between 14 and 20. So as we started doing some of these patients, the neonatology group just started increasing their PEEPs empirically, which was a challenge for us to keep up with for this study. And then if we look at these 12 patients and where we ended up, so we increased the PEEP in a certain portion. We actually reduced the PEEP in one patient, and in 3 of them we made no changes. So you can see kind of where our beginning PEEP was, where our ending PEEP was, and we did have 2 patients that we ended up on 24 of PEEP, and they benefited from that greatly with a decrease in their wasted efforts. And you can see subject number 10 there started on 14. We just went up to 18 a PEEP, but we reduced their wasted efforts from 40% to 17%, which was an amazing reduction for such a small increase in PEEP that we were surprised at. So you don't always need a big change to get a big result. So again, looking at these babies, our PIPs, which is important, we thought, we saw a statistically significant difference in the mean increase in PEEP, or PIPs, with our mean increase in PEEP, which is understandable. You're going to see that. But if looking at that, for that same major difference in PIP that we saw with that wide PEEP range, we didn't see that much of a difference in our mean airway pressure. So we weren't increasing the pressure as much, but we did see a significant reduction in wasted efforts over time. There were a lot of babies as we were doing our PEEP increases for this study that we increased their PEEP by 5 to 10 before we even saw an increase in their PIP. So a lot of times we were just offsetting some of that intrinsic PEEP, and we weren't seeing that result in their peak inspiratory pressures. It was incredible to really watch. So going beyond our ventilation strategies, and about 10 minutes left here. We have aerosolized therapies. We use a lot of bronchodilators. I think everybody does, because hey, you got to try them. They're just nebs. let's give them a try. But as you can see with a lot of the different phenotypes that we had prior, there could be some challenges with bronchodilators. And remember that bronchoconstriction doesn't always cause wheezing. It's just turbulent airflow. So sometimes you could fix that with other measures like PEEP. So trials can be done, but we really need, again, to know what are we looking for to see if this therapy is actually effective. So we did a study looking at our aerosolized albuterol patients, and it says it's unpublished. This was published. I should have put my new reference in there. I apologize for that. We can send it out. But we did try to determine the safety and effectiveness of aerosolized albuterol in infants that had severe PPD. We did a blinded, randomized, placebo-controlled crossover trial of 24 infants. So they had 3 treatment groups. With each treatment group, they got a therapy or a dose of neb every 4 hours times 24 hours. And then we had a 6-hour washout phase in between each. That way we knew the safety effects or any heart rate increases or blood pressure increases would actually be related to the therapy that they were getting, not the past therapy. And it was a block randomization, so each treatment scheme was equally distributed so that we could really compare these. And our primary outcome measure was looking at a change in expiratory flow at 75% of exhalation. That was our efficacy outcome, and then our safety outcome was a change in heart rate. And as you can see here, we saw a percent change in PIP that was statistically significant for albuterol of 2.5 milligrams versus placebo. And I'll qualify this with we volume ventilate primarily in our patients. So every one of these babies was volume ventilated. So PIP was the appropriate measurement for us to be looking at here. But you didn't see that with 1.25 milligrams of albuterol. So doing a half dose just because they're babies, as our center did prior, isn't really effective. If you're going to see a difference, you need to use a full dose. We did see a statistically significant change in heart rate, an increase with that 2.5 milligrams of albuterol. But as you can see, it was only a 3% change. And as we know from having to monitor our patients, most of our policies at hospitals, you don't even stop the therapy and notify the physician unless you get a 10% change in heart rate from baseline. So even though this 3% change was statistically significant, it really isn't clinically significant that it should stop us from really giving an optimal dose for efficacy. Other medications that we deliver are corticosteroids. There are no good trials to be done on this or long-term outcomes. Mucolytics, there's a couple trials in preemies looking at Dornase versus hypertonic, but only for about 48 hours, but no real good studies in the BPD population. So new management concepts that we're kind of looking into here is our older infants with established lung disease, really making sure that they have adequate respiratory support is really important. BPD will not get better. It can only get worse if you don't care for it appropriately. You have to let them grow. And you can't grow their lungs if they're struggling to breathe. So we really can only make injury worse. Lung disease and BPD are not all the same. We really need to look at them and individualize the treatment amongst the patients. And this really is a multi-system problem. It isn't just the lungs. And we can't treat just the lungs. We have to treat all of it because there are a lot of things that we could be doing that are affecting the lung growth if we don't manage those as well. And really, we need to try to develop a concept of neurodevelopmental respiratory care as well and think about what we're doing and how it affects the brain. It might not make a difference long-term with our pulmonary management, but it might make a big difference with our long-term neurodevelopment, just like stopping those swings and desaturations. We get so used to them, we think it's not a big deal, but we're seeing that neurodevelopmentally it is a big deal for these babies. So for multi-system disease, we really need to have a multidisciplinary team, and this is our group. We meet every Tuesday, and everybody really talks about how their particular specialty system is affecting the overall, and we'll discuss a lot of these things and titrate and change what we do according to some of that, because we know that BPD is a problem beyond the newborn period, and these kids grow up, and we need to do our best to make sure that they are at their best when they get out of our NICU. So we don't have any really good long-term epidemiological data at this point. Still, we have some retrospective data on outcomes that I'll share with you briefly. But we know there's a lot of epidemiological studies that are ongoing, and it's going to take us some time to really get some good data on that and then see how we change our treatment. In the queue, it's going to take several years for us to know if that made an effort in our neurodevelopment standpoint. So this is kind of lung function of infants that had BPD as they become older children and adolescents, and you can see the controls are in the blue, and in the red are those who are survivors of bronchopulmonary dysplasia. And you can see that they do kind of get up to close to their lung growth as to where they should be. They don't get all the way to normal, but they do get up there. But they're always going to be a little bit reduced in what their lung capacity is over time. We never really make it back to where we should. And then, as you can see, this is use of data from a prior trial, from the indomethacin trial, but we really saw that the more number of comorbidities you have, the greater probability of poor outcomes at 18 months. So if you have a kid that has BPD, plus they have an IVH, plus they have ROP, then that just further complicates and makes it harder for them to get better neurodevelopmental outcomes over time. So at 18 months, we know that we're seeing these kids have a greater odds for CP. We're also seeing by school year age, they have worse cognitive performance. So we really do need to concentrate on their neurodevelopment because they have a lot of visual problems. They have a lot of sensory problems still, and we can't just concentrate on the lungs. And lastly, this is a slide of a study that came out of Canada that this is not real data. This is a micro simulation that they did looking at a lot of the information that they have within the Canadian health system that is an estimate of lifetime health care costs and healthcare utilization. So you can see within year 2 how many admissions that you have if you're mild, moderate, or severe BPD, how much your risk of complications are for neurodevelopment, developmental delay. And some of these, it increases over time, and some of it doesn't with your severity. So these are definitely things that we need to be looking into long term.